Hi, today I want to give you some tools on how to assess your real risk for heart attacks and strokes. Hi, my name is Chad Campbell. I am a certified functional medicine provider with Redesign U, and today we're going to talk about cholesterol and reducing our risk. Last week we talked about how it's always been told that heart attacks and strokes happen by a plaque building up inside of the artery wall as we age, and then it becomes 100% blocked, which then causes the heart attack or stroke. Well, now we know that it's actually happening inside of the blood vessel wall. And that if you imagine that plaque in the wall is like a dynamite, and then some type of trigger or inflammatory process lights that dynamite and it explodes into the actual blood vessel wall. And that's what causes the true heart attack or stroke. So today I want to show you some ways that a functional medicine provider might look at what are your true risks and your real risks for having these heart attacks and strokes. I'm going to try to make this as interesting as possible, and I hope that you guys can hang with me because it's some testing and lots of testing and tools that you can use, and I hope I don't lose you on this. But this is the real way to test for this stuff. So total cholesterol, we need cholesterol. Cholesterol is what starts the process for all of our hormones, for our sex hormones, for our testosterones, and for our androgens, and we also need it for cell health. Triglycerides provide our body with energy and store the energy for later use. So we want to keep our cholesterol less than 200 because anything above 200 increases our risks for heart attacks and strokes. And we want to keep our triglycerides less than 150 because we don't want too much fat deposits throughout our body. The bad cholesterol, the LDL, is what transports cholesterol to the tissue. Remember, we need the cholesterol. We need it in order to make hormones, and we need it for the cell health. So LDL tells us how many of these transporters do we have trying to transport this cholesterol. Stress can also make this LDL go up. And then we have the HDL. HDL is what takes the cholesterol from the blood vessels or from the tissues and takes it back to the liver. So it's like the garbage truck driving around, collecting the garbage of cholesterol, taking it back to the liver in order for it to be taken out of our body or recirculated within the body to make more of the hormones and to help the cells. Our body's smart. It knows how to do this. So this is a good test, but it's not sufficient enough. It's not good enough. Because remember, more than 60% of people who have heart attacks have normal cholesterol, under 200, or an LDL under 120. And 50% of those people have no risk factor for that heart attack or stroke, meaning they don't smoke, they're not obese, their genetics are fine, and they don't have high cholesterol. So this is why in functional medicine and at Redesign U, we want to go deeper. It's not to spend money. It's not just to order a bunch of tests. It's to find out that person sitting right in front of you. What are they at risk for? What are the things which can cause them to have this unexpected heart attack or stroke when they think that they're doing wonderful because their cholesterol is normal? That's what I want to talk about. So let's do it. Hang with me, okay? Let's go through this. So we always order an NMR. And an NMR is kind of like an MRI of your cholesterol. It tells us particle size. So we have the LDL, that bad cholesterol, LDL-P, or LDL particle size. And what we're looking at with this is how much of that cholesterol is built up in those walls, how much particle sizes of each of these large or small. So a large particle size shows that it's big and fluffy, bad cholesterol, right? The small LDL-P or particle size is a much higher risk for the heart attacks and strokes. It's actually 1.7 times higher for a heart attack or stroke. The point is that the particle size is the risk. The particle size. And so if the LDL-P is elevated, that tells us how much gravel is actually in those trucks. How much gravel is actually filling these things up. Those small LDL particles are more prone to what's called oxidation, meaning they rust. So it's like the arteries are becoming rusted with these small LDL particles. And that's what causes a high risk for atherosclerosis or for those plaque buildups inside of the walls. So from what we like to do is we like to order the LDL-P to tell us how much of a load, how much rust could possibly be going on in there, even when the cholesterol is normal. If that's high, that is an enormous risk for heart attacks and strokes. The more particles you have, the more risk that you have. And you can even assume that if your triglycerides, just a little pearl, if your triglycerides are higher than 250, then you're dealing with small LDL particles. If your triglycerides are less than 150, you're most likely not dealing with small LDL particles. So then you think about the HDL, the transporters that are the garbage trucks that are going and taking all of the cholesterol and taking it back to the liver in order for it to either be removed or recirculated. So again, HDL is considered the good cholesterol, but even the small particles in an HDL can be a problem. So we want to, again, try to get big, fluffy HDL size of those particles. And another great thing about the NMR is it also gives us an insulin resistance score. Insulin is a huge inflammatory marker. We're going to talk about that in a little bit. But the insulin resistance, the higher it is, the more insults, the more detonators happening for that dynamite to actually explode. And insulin is a huge thing that we're going to talk about here in a minute. So some of these genetic lipid disorders that you can actually check for, ApoB. ApoB binds to that bad cholesterol, and it can give us a measure of how much LDL there actually is. The reason why this is super important as a genetic disorder is if it's elevated, it increases your risk for heart attacks or strokes 2 to 3 times. 2 to 3 times higher. So if you look at just that cholesterol, but that ApoB is high, 2 to 3 times higher risk of having that heart attack or stroke. It correlates with how much of a plaque buildup from that particle size, the particle numbers in the artery walls. ApoA is what gives the HDL the ability to take the cholesterol out of the blood vessel or out of the tissue. So if you have an ApoA genetic disorder, you're having a very difficult time getting the cholesterol out of the tissue. So that's why what we'll do is we take the ApoB and ApoA ratio, and it gives us a lot of good understanding of how much of a risk, because if we have a lot of ApoB, a lot of LDL particles with a low A, meaning the inability to get it out of those tissues, we have a huge risk for the heart attacks and stroke. So we would want to address that instead. Lipoprotein A is another genetic disorder. And what it does is lipoprotein A works like plasminogen or like fibrinogen. So when we form a clot, lipoprotein A will give us the ability to break that down. So if we have a lipoprotein A problem, we're not able to break these clots down when they form, which then increases the risks of those heart attacks and strokes because our body can't get rid of those clots. And there's another one which is called PCSK9. I say that 100 times. But PCSK9 is another genetic disorder, which is actually pretty fascinating because when the cholesterols are brought back to the liver and they bind with that receptor, what it does is it comes down into the liver, and then the cholesterol is separated into sides. Is it going to make it recirculate, or is it going to get rid of it in bile? What happens when that receptor comes down inside the liver is that PCSK9 will bind with that receptor and destroys it. So it can't go back up to keep doing its job. So what will happen is people will start taking statin therapy, or they're doing everything they can do and their cholesterol continues to go up. they may not have any more of those they may not have enough of those receptors because they keep getting destroyed by a genetic disorder, PCSK9. And there are so many more of these, like ApoE. But when we think about this stuff and we're talking about all these kind of things, we're just trying to figure out, what is that person at risk for? What is that person got going on when you look at the whole picture? So if we look at some of these things that we talked about, we're still like, still not seeing it. There are some other ones you can do, like what's called an ADMA arginine ratio. And what that means is that arginine is needed to make nitric oxide for the blood vessels. And nitric oxide is the all in all for the blood vessels. It's like the health of those blood vessels. It gives them the ability to open and close. It gives them that elasticity that they need to be able to do. Well, this ADMA competes with arginine. And so what happens is if arginine becomes deficient, then the vessel wall is not doing good. It makes it sick. And when it makes it sick, it increases those risks for those heart attacks or strokes. ADMA is increased by proton pump inhibitors. I know. By like omeprazole, Prilosec, Nexium, by all of these medicines, it shows that it increases the risk of the ADMA. Oxidized LDL increases ADMA, and so does the homocysteine. Homocysteine, we're going to talk a little bit, but homocysteine is a level that we monitor that can show that if an elevated homocysteine level, it can increase your risk of heart attacks or strokes by 300%. And it's a methylation where your body's not able to methylate and it's not able to convert certain things that it needs for the DNA and for cell health. B6 deficiency, B12 deficiency, folate problems, those all can increase homocysteine, as well as smoking and alcohol. Alcohol increases the risk or increases homocysteine levels. And the other one I want to talk about is TMAO. TMAO is a certain pathogenic bacteria that actually is in the gut that it increases the TMA increases when this bacteria binds with an amino acid, and then that causes atherosclerosis. So many times it's actually in the gut. It's somewhere else. It's not just an artery filling up. So some of the things we always want to do is always assess for inflammation. And people kind of like, why does it always go back to everything seems to be about this inflammation? One of the reasons is because when there's inflammation, it's because there's been some kind of trauma. Something is causing it to get inflamed. And when that happens, cells separate so that more blood flow can get to those areas to be able to heal whatever the inflammation is being caused by. But when that happens, more LDL particles can get in there as well, meaning that it makes that vessel wall even more sick. It makes it unhealthy. And when that happens, that rust, that oxidation starts setting in inside of that vessel wall, which then causes more atherosclerosis. So it's kind of like, that's why all of these different things are so important to look at. So one of the inflammatory markers we'll check is what's called a CRP, or C-reactive protein. There is an HS-CRP, which is more specific for heart, but a CRP in general tells us how much inflammation is happening in the body. The homocysteine is the other one, like we talked about, that can increase your risk 300% for heart attacks. And then LPPLA2. LPPLA2 is more specific for vascular inflammation, inflammation happening in your blood vessel walls. That oxidation, that rust that's happening inside of those walls, that's what this test is really good for. One thing that we always think about with abnormal LPPLA2 is if there is some type of HDL dysfunction. Remember, HDL is what takes the cholesterol out of the walls. So if it's not able to get out of the walls and there's a lot of inflammation happening in there, we're thinking, maybe there's some type of HDL problem where they can't get it out. Even if the HDL levels are normal, even if they're normal, there can still be an HDL problem. And insulin causes inflammation. in everything. And this is why we're always going back to sugar and weight and too much carbs, which we'll talk about in a little bit. And some other things that people may not know about is sleep apnea is huge in causing heart attacks and strokes. We call it the silent killer, as well as gingivitis and bad teeth. Gingivitis is such a huge risk factor that one of the things that we're starting to do, if somebody is having these higher scores and these higher tests for this atherosclerosis, for these heart disease tests, then we want to go looking at their teeth. We say, go to the dentist, get those teeth checked out, get those teeth fixed, because it's really increasing your risk, and it's really going to cause some problems if we don't. So if we think about all of these things that these tests, I hope you're able to stay with me during all this stuff. If you're able to think about all these kind of things and all these different little tests that we think about, all we're looking at is we've got this dynamite in the wall. There's a detonator which is going to make it explode. How do we see what those detonators are? How do we control the detonators? If we're not able to always control the plaque or the dynamite, at least we can do our best to control the detonators. So when we talked last week, we talked about stress tests and how stress tests detect a blockage of blood flow of 70% or more. The problem with that is 86% of heart attacks occur in patients with plaque blockage of less than 70%. 86% of them aren't going to be seen on a stress test. So people are like, oh my goodness, this is the person who had the stress test and then dies of a heart attack a month later while out mowing the grass. 86% do not have a blockage of more than 70%. And of that, 50% of those people have normal cholesterol levels. Not all the tests that we talked about. They have the normal total cholesterol and normal LDL. So I say, well, what about my EKG? My EKG was normal. Well, the EKG tests just a very short amount of time of what your heart rhythm and rates are doing. So we can't always go off of the normal cholesterol panel, off of an EKG or a stress test. So one of the tests that we like to order is called a coronary calcium score. And what it does is it tells us how much calcifications are actually in the blood vessel walls of the coronary arteries, in the walls. And more than 100 is considered high risk, meaning there's a lot of rust in those pipes. And we need to really figure out what's causing that rust buildup inside of there. So the higher the number, the more proportional risk for causing heart disease. If you're a 0 or taking statins, it doesn't show any difference. It doesn't. So if the coronary calcium score is 0 and you take statins, it doesn't show any difference than if you take, if your score is 0 and you're not taking statins. So I can say this, that I have high cholesterol. My cholesterol was 270 something, 280 the last time we checked it, with an LDL of 160. What did I do? I did a coronary calcium score. Comes back as 0. So what am I doing? I am affecting and I am trying to address all of those detonators so that it doesn't explode my dynamite. And I'll check that calcium score again down the road. But for now, I'm just approaching the detonators. Another test we look at is called a carotid IMT, which measures the thickness of the vessel walls inside of your neck. And is there a lot of plaque buildup inside of there? We always assume if we're seeing plaque buildup in the legs or in the arteries in the neck or in the head, it's also in the heart, and we're going to address it. So these are tools that we can use. These are some new tools, hopefully, that you didn't know about that you can really think about. And then when we think about these interventions, we always think about the detonator. Again, we're looking at what is the detonator? What are things that we can do to not set off this dynamite? Because we can no longer assess someone's risk for heart disease by just checking the lipid panel. Can't do that. And we can no longer assume that everybody needs statins. There's a huge place for statins. I am not saying that. What I'm saying is just because someone's cholesterol is high does not mean they need statins. We need to assess those risks and break it down to what's causing that cholesterol to be high. Who's this person in front of me? Who's this person in front of me? And this is what we want to do. This is what we do in functional medicine. And this is what we would like for you to ask for with your providers. So we want to reduce the inflammation. We want to reduce the detonators. Sleep. Is there sleep apnea? No. Okay. How much sleep are you getting? Reduce that detonator. Movement. We want you moving. I am not talking about CrossFit. When we talk about heart health, we're talking walking, taking a walk, doing some resistance training. Those are the things that we're talking about, not CrossFit, okay? Stimulating what we call the parasympathetic system, which is the opposite of that whole fight or flight, driving. How do you get yourself to relax? For the blood vessels to relax, for everything to just, because those are all things to help reduce the risks of those detonators. Dietary choices. You will hear about them over and over again. You know those things. If you don't, check them out. But one of the things we want to try to get you to do is a focus on keeping the sugars low to prevent the insulin levels from going so high. So if you think about insulin is the trigger to set off that dynamite, maybe that might help you think about the next thing that you eat and not doing so much of it, you know, instead of it just doing it because somebody tells you to do it. Smoking and chewing tobacco, they cause vasoconstriction, and they are detonators for the dynamite. And reducing alcohol. You know, it's always been alcohol can help reduce risk of heart attacks and strokes. 2 glasses of wine in a male, 1 glass of wine in a female. The problem is the more we're learning, what we're seeing is that the alcohol can increase the small HDL. It's the small HDL, which isn't as helpful for us as it was thought. Turmeric is wonderful for inflammation. If you want to take it for heart and for joints, you have to take it with some type of pepper base as well. Otherwise, it won't get absorbed and it just sits in the intestines, but it's a good anti-inflammatory for in the intestines. So you figure out how you want to use it. And fish oil. If you don't eat fish more than twice a week, omega fish oils are still shown to be very helpful. We talked about the homocysteine can increase your risk 300 times for that heart attack. So avoiding the alcohol, working on methylation. We use N-acetylcysteine or fixed B6, fixed B12, fixed folates, fish oil, decreasing meat. Those all help with homocysteine. That lipoprotein A genetic thing can be through, we can help that with niacin. Avoiding PPIs for stomach, for reflux because of that ADMA arginine ratio to help with that nitric oxide so that the blood vessels can open and close the way they need. We may have to work on the gut because of that TMAO. If that bacteria is binding with those amino acids, creating that atherosclerosis, it could be a big problem inside of your gut. And that's why we in functional medicine always still feel the gut is the foundation of your home. We're going to address that gut before we address anything else, because many times everything else, including low testosterone, messed up estrogen levels, adrenal weird stuff going on inside there, high cholesterol, many times those are all just downward effects of an abnormal gut absorption. PCSK9, we can deal with that with niacin. Berberine is used in that to try to help with those things. So you can see there's all multiple things that we can do to reduce the risks. The most important thing is that person sitting in front of you, you looking in the mirror, you know yourself better than anybody else. What are detonators that could set off that dynamite in front of you? What do you have risks for? Is your gut jacked up? Do you drink too much alcohol? Are you smoking or chewing? Could you have these other genetic disorders? Do you have too much of that particles in there? Because when we figure out those things, we can address those individual things. And that is the true way to reduce your risks for heart attacks and strokes. So I hope I gave you some good tools for you to talk to your provider about to help reduce your risks of heart attacks and strokes. And remember, me and my team here at Redesign You, we're always here to help you to achieve your health goals. So next week, I interview one of my good friends, integrative cardiologist, Dave Johnson, who has been practicing for more than 23 years. I hope you tune in with us. It will be next Sunday, March 1st at 6 p.m. Arizona time, 8 p.m. Eastern. I'll talk to you soon.